Good evening, everyone, and
Right.
welcome to the webinar on the theme Catalyzing Cancer Care Emerging Trends and Innovation. It gives me great pleasure to invite our program director, Dr. AVS Suresh, medical oncologist and hematologist from Hyderabad, to give the context setting. Over to you, sir.
Thank you very much. Can you see the PPT?
So you'll have to share your screen, sir.
Okay, I have to share. Okay, just a minute. Okay. Can you see now? Right. So, the cancer care is changing very rapidly over a period of time. We are moving more towards personalized medicines, and personalized medicine is highly dependent on it's highly dependent upon the genetic makeup of the disease and person's ability to fight the cancer. So today we split the session into how the genomics are helping in navigating in the oncology, which will be taken up by Dr. Rachana. And we are going to discuss about reinventing the adjuvant therapy in the EGFR positive lung cancer patients. Dr. Shikhar is going to take us through that. And this will be followed by a 35 minutes of interactive session where I'll be discussing with Dr. Sharat Chandra, Dr. Pradeep, Dr. Naresh, Dr. Sreekanth, Dr. Mahati, as well as Dr. Sai Krishna. And this will be followed by a short session on the immunotherapy in early lung cancer. Where are we? This will be dealt by Srinath. And then what that MET exon 14 we have as on today will be dealt by Dr. B. Srikanth. So without wasting much of time, I may now request Dr. Rachana to please start the session. She is a medical oncologist in Hyderabad. We all know her. Please, over to you, ma'am.
Yeah. Good evening, sir. Thank you, Suresh, sir, for giving me this opportunity. And I would like to share my screen for the presentation.
Sure, ma'am.
Can you see my screen? Is my screen visible?
Yes, ma'am.
And the slideshow?
Perfect, ma'am.
Yeah. Okay. Thank you, AstraZeneca, also for providing me the slide deck and giving me this opportunity to speak on NGS, which is the most hot topic now for all the medical oncologists, not only for lung cancer, but most of the tumors we are trying to find out any actionable mutations in by doing NGS. And the first tumor where everything, the molecular or the precision oncology, all of this have started with NSLC only. And the classification of NSLC has evolved from the histology-based classification to a molecular-based classification based on the type of mutation present. And further down, we are more dividing the mutations into the different variants. Like in EGFR, we have so many different mutations or insertions and sensitizing mutations. So the molecular landscape of NSCLC is vast, with the actionable mutations which we all generally test include the EGFR mutations, KRAS, ALK, HER2, MET, especially the MET exon 14 skipping mutation, the ROS1, BRAF, RET, and NTRK. We do have targeted therapies for most of these actionable mutations available in India also. The most common mutations, though the slide is showing around 20% of EGFR mutations, Asian populations are known to have a higher incidence of EGFR mutations, especially in the non-smokers and females, approximately around 40 to 50%. Even ALK fusions are also seen more higher in our Asian population. Our own institute experience, we have a 8% incidence of ALK positive cases. KRAS G12C is another common mutation which we generally see in patients with NSCLC. So over the past decade, there is a growing list of specific predictive biomarkers for actionable genetic alterations, and this will continue to grow further. So the past was most of histology-based, and the clinical pathological factors used to decide, like whether you want to go with the pemetrexed-based chemotherapy with the platinum or the paclitaxel chemotherapy. This was only histology based and mainly done on the tissue only. But now we are moving away from the tissue. We are also using the plasma based analysis, which may become a main test which we do for most of our patients in the future. Presently, we are trying to use both the liquid and the tissue biopsies to get a proper report and to do a proper management of the patients with the various tests available like the PCR, FISH, IHC, Sanger sequencing, and the next generation sequencing also. So the IHC based analysis of the lung cancer was TTF1, P63, dividing into adeno or squamous cell carcinoma. Then moving on to the genes which we have already discussed. So the need for the biomarker testing has accelerated in the recent years, especially with the development of targeted therapies and immunotherapies. So the initial mutation which was identified was not EGFR, but the BRAF mutation in 2002, followed by EGFR, Metexon, and Alcan-ROS. And you can see the various targeted therapies available for different mutations and the years they were approved in the purple boxes. And the green boxes are for the immunotherapy drugs, which are being used based on the PD-L1 status, most of the times based on the PD-L1 status. We do have few indications where we can use irrespective of the PD-L1, especially in combination with the chemotherapy in the first line setting. So what are the different methods which we have access to for analyzing the biomarkers? We have the PCR, we have the IHC, we have the FISH, we have the NGS. But what is the good diagnostic test among all of these? The good diagnostic test, it should be accurate, quick, simple, accessible. It should be cheaper also, especially for the Indian population who are not very affordable and majority do not have a medical insurance. The cost is one factor which plays a major role in deciding the type of investigation we do. And the amount of tissue required is also minimal for a good test, because a biopsy from the lung is not an easy thing to attain large chunks of tissue, especially in the metastatic setting. Sometimes you don't even be able to do a biopsy because of inaccessible sites. So whatever tissue is available, that should be used to give us the best reports and the quality reports also. A mutation-specific test should sufficiently cover the gene variants which are typical for that particular disease. It should be sensitive and it should yield clinically relevant results. So identification of the predictive biomarkers has shifted the treatment of lung cancer. It is mainly used for treatment decisions for patients with advanced NSLC. But yes, we are moving to the early stage lung cancers also. Previously, it was only the metastatic setting. Now, even in the early stage, we are doing the molecular testing and we are planning our adjuvant therapies based on the molecular analysis. And this biomarker testing will help us to identify those patients who are most likely respond to targeted therapies and immunotherapies. All of us were doing single gene testing till past 3 or 4 years, but most of us have now shifted ourselves and are getting an NGS done, either limited panel NGS or the full panel NGS. So what is this NGS? This is a next generation sequencing which has been built upon the Sanger sequencing, uses various fluorescent terminator nucleic acids, but NGS is able to determine the sequence after each nucleic acid is incorporated, allowing for the simultaneous sequencing of multiple genes. There are different platforms which are available for doing the NGS, each utilizing a different detection methods and technologies. It mainly involves the DNA extraction from the patient samples, fragmentation of the DNA, preparation of the library, sequencing, and then bioinformatic analysis, and finally generating the report with the data interpretation. So various NGS sequencing platforms and library preparation kits are available, which include whole genome sequencing. You can do a whole exome sequencing, or as in the limited panels, you can just do a targeted sequencing. So you want a broad panel, you can do a whole genome sequencing. You want only few tests to be done, you can still do a targeted, targeted gene sequencing. So this is a brief overview of how NGS is done. As confusing as the image looks, the NGS testing is also confusing only, but yes, the final report is what is actually important for us. But we should also be aware of different steps which happen. Isolation of the DNA, fragmentation of the DNA, preparing the library and enriching the DNA copies. And if you want to do a limited PCR, you can do it on the enriched library, or you can do a paired and next generation sequencing and do a whole genome or whole exome sequencing. With tier 1 and tier 2 informatics, you can finally develop your report. So we generally hear the terms when we use NGS, either a DNA-based NGS or an RNA-based NGS. So there are some advantages of both the tests. It's not that one is completely superior over the other, or you can exclude one and do the other one. DNA-based testing is generally preferred for detection of exonic mutations, while RNA-based is usually helpful for detection of fusions. So fusions are not generally identified only by DNA-based testing. So if you're doing a DNA-based testing, the RNA-based testing can help you in identifying these genomic alterations, such as the complex gene fusions and the splicing events. What are the DNA-based testing do? They sequence the exons and introns in the promoter regions. They can identify the single nucleotide variants, copy number variants, rearrangements, exact gene fusion breakpoints, and they provide a high resolution reports of the genome or the exome. But we have to think about the fusion partners, which are not commonly known, might be missed on the DNA sequencing. And effect of the genetic alterations on the gene expressions have to be predicted. Whereas in the RNA testing, you only transcriptomes, the exons are been done. You can do the single nucleotide variants in insertions, deletions, and gene fusions. These are what you can identify with your RNA-based testing. So using a DNA-based testing complemented with an RNA-based testing will yield the better results or the best results of NGS instead of using a single testing alone. So whatever we are doing is finally for the patient. So when you are thinking of a patient-centered treatment, then you have to do only one single test, which will able to identify multiple targets which can be actioned upon. So the drugs are also available for different targets. So wherever feasible, try to get a multi-gene panel done on the limited amount of tissue which is available, rather than doing a stepwise approach of one molecular test followed by the another, because tissue is not generally sufficient if you want to go by individual molecular analysis. So this is how the genome characterization occurs with the use of FISH, IHC, pyrosequencing, NGS, and massive parallel sequencing. So it's, if you see the initial era of starting of the next generation sequencing, the price was almost close to 1 million genome. Then now it has come down to $10,000, and now around 2014, the price has come down to $1,000. And we know in our own clinical practice, we are seeing limited genes and panel is being done for around 8 to 9,000, thanks to the help of the pharma companies who are supporting our patients by giving some discounts on the NGS panel, and 8,000 rupees for a limited gene NGS testing for NSLC is actually helping a lot of patients to identify those who can benefit from the therapy. So these are all the clinically actionable mutations which we all are aware of in NSCLC, and these are all our actionable mutations in the NSCLC. So NCCN guidelines also recommends us to do a biomarker testing for all patients and then plan your treatment. So initially, don't directly jump to NGS. First, try to establish the histology, whether it is an adenocarcinoma, squamous cell, or the large cell. And if it is a metastatic disease, do the biomarker testing along with the PDL1 so that you can plan your immunotherapy for a driver negative NSCLCs. And at least try to do the limited gene NGS panel for the targeted actionable mutations. So it is not only the test, but also your sample collection and the process of storing it, or process of how you process it to extract the DNA. All these factors also affect the results in NSCLCs. So you cannot blame the lab alone that this is wrong, this report has not been given, or they're not able to analyze. It could be a problem in the cold ischemia time, that is the fixing the tumor tissue as soon as possible is very important. Stabilization in the required fixate tube, like the formalin, is also very important. The processing of the tissue is also very important, as does the tissue processor variables and the storage condition. And after all this, the proper documentation and proper interpretation of the report is also important for us to plan proper management for the patient. So these are all the tissue conservation methods and the management strategies which help us to get the better NGS results to plan the treatment for our patients. So a number of factors should be considered when choosing an NGS as a biomarker testing method. You have to see what is the sample you want to give, whether it is a liquid or a tumor tissue. What is the depth of analysis which that particular NGS platform can do? And number of genes you want to test, whether you want to do a whole genome sequencing or you just want to do a limited number of genes. And what is the turnaround time? Which symptomatic and SCLC patients, it becomes more important that you get your NGS reports as fast as possible. And cost factor, which is always there. So these are all the factors you have to consider when you're planning for asking or requesting for an NGS testing for your patient. So you have to see what is the sample you want to send, number of genes you want to do, and what is the depth of coverage for the NGS platform. Advantages of NGS that it is highly sensitive and it is capable of detecting single mutations and genetic rearrangements. Disadvantages, it is time consuming. Yes, we do take around 14 days of at a minimum period to get an NGS report. It will miss some alterations like the fusions if you are doing only the DNA based NGS. And the biomarkers which are detected are generally the point mutations, metaxon 14 skipping, and the copy number variations. Detection of patients with an actionable biomarker may be improved with integration of liquid biopsy testing. So first, if you do that, see, if you want to do a tissue and liquid biopsy, just excuse me for a second. I'll just. So number of patients with metastatic NSLC are diagnosed, identified with an NCCN guidelines recommend a biomarking testing methodology. Either you can do a tissue first, or you can do a liquid first, or you can do a tissue plus liquid. We know majority of the key opinion leaders or or most of the oncologists do try to prefer to do both tissue and liquid biopsy tissue plus liquid biopsy, which will increase the yield of the molecularly targeted therapy with 48% increment if you use both the tissue and the liquid biopsy upfront for diagnosing the NSCLC molecular mutations. So we have various analyses which have shown that liquid biopsy is highly concordant along with the tissue-based testing. If you see this table, you can see the sensitivity and specificity. Specificity is almost 100% with a concordance of 98 to 99%. And this is for most of the genes of the EGFR, ALK, ROS, and BRAF. So whenever there is a problem of accessing a biopsy site, doing a liquid biopsy is good enough and you'll get a similar results as you do a tissue biopsy. But yes, you might miss upon the histology if you're not able to do a tissue biopsy. And the heterogeneity of the tumor per se will affect if you only do a tissue biopsy. So adding a tissue biopsy along with liquid biopsy will give you the better results and the better identification of the molecular alterations. And treating patients with targeted therapy based on the results from liquid biopsy have also resulted in better outcomes. That is, patients who are diagnosed with a molecular mutation on liquid biopsy, 85.7% achieved either a complete or a partial response or a stable disease. So you can see that if the mutation is there on the liquid biopsy, you should not doubt that it may not be a targetable mutation. If you have a drug which is actionable for that particular mutation identified on liquid biopsy, yes, we do expect our patients to respond to the targeted therapy available. So if you do a tissue plus liquid concurrently, high chance of identifying the actionable mutations. Turnaround time may be a bit higher if you want to do both of them together, and cost of testing will obviously increase. If you do a liquid first, detection is faster. You can detect most of the actionable mutations. Turnaround time may be higher. If you want to do a reflex test on the tissue, cost is also on the higher side. If you want to do only liquid analysis, the chance of detection of actionable driver mutations may be slightly lower. So if you see, finally, it is always preferable to do a tissue plus liquid concurrently if cost is not an issue. So to conclude, the new methods such as NGS shows immense promise for the future. NGS gene panel helps in multiplex key actionable mutations for a cost-effective, accurate, and a sensitive assay. And targeted cancer panels are useful for drug repurposing of small molecular inhibitors. So if you want, you can do just the targeted panel only rather than doing the whole genome sequencing. Pre-analytical issues are a major concern. So proper processing and storage of the tissues and the proper method of doing the NGS is very important to get a better results. And detection of the patients with an actionable biomarker may be improved with integration of liquid biopsy testing. Thank you.
Thank you, Dr. Rachana. It's quite time. Thank you very much. As usual, it's excellent.
Thank you.
Now we move on to the next topic. May I have Dr. Shikhar Kumar. We take all the questions during the panel discussion. So keep your questions waiting for the panel discussion. Dr. Shikhar, you can just continue with your reinventing the adjuvant therapy in the EGFR mutated early lung cancer patients.
Thank you, sir.
Welcome.
Can I have my slides, please? Right. Thank you to AstraZeneca for calling us here and for giving us these slides. So as we have already heard from Rachana ma'am, the prevalence of EGFR mutations in the Asian population is much higher than what is reported in the West, with around 40 to 50% rates of EGFR mutation in our population, and possibly even higher than that. Analysis from several institutes like TMH in Bombay have revealed that the prevalence of driver mutations, including all mutations, could be as high as 60 to 65%. So in that setting, it is very important to understand that how from the stage 4 setting, we have now moved the needle of the targeted therapies like EGFR inhibitors into the early stages of lung cancer. So coming to the next slide. So we all know that for stage 4 lung cancers, even with patients who have these driver mutations, their survival is measured in years. But in the case of early stage lung cancers as well, contrary to what is popularly believed that these would be cured with the prevailing treatment, that is surgery and chemotherapy, the 5-year survival leaves a lot to be desired. As you can see that the 5-year survival drops down from around 65 to 75% for stage 1B lung cancers to almost 30 to 40% in stage 3A and 3B lung cancers, indicating a huge unmet need in this patient population as well. Next. So the current recommendation to test for the markers in an early stage operable lung cancer is to test for the EGFR mutations, that is the common sensitizing EGFR mutations, the exon 19 deletion, L858R exon 21 mutation, and PDL1. And now with the data of the ALINA trial available, we would also have test for ALK mutations as well. Next. So we will discuss as to why it is recommended to test for EGFR mutations in this patient subgroup. But as you can see here, the prevalence of the common EGFR mutations is almost equal between the two most common mutations that we see in our practice, that is exon 21 L858R mutation and the exon 19 deletion. Next. So overall, if you see the gold standard of therapy in early stage resectable lung adenocarcinoma, that is stage 1A to stage 3A, remains surgery. And more than 2/3 of these patients would undergo surgical resection, but probably only half of them would receive some form of systemic therapy in the adjuvant setting. Next. So despite undergoing a curative intent surgery, we know that almost half of these patients would recur in the next 4 to 5 years of time. And that is where I was discussing about the unmet need. That is, there is the need for improvement of the systemic therapy options, either in the neoadjuvant or in the adjuvant space, to reduce these recurrence rates. Next. So we all know that platinum-based chemotherapy, whether it is pemetrexed cisplatin or vinorelbine cisplatin, has been used in the past with some effect that you can see that there's roughly a 5% improvement in the disease-free survival and overall survival at 5 years, which is predominantly seen in patients who have stage 2 and stage 3A disease, and to a smaller extent in patients who have stage 1B disease. But as you can see, this effect is quite modest and it still leaves a lot to be desired because there is a continuous pattern of relapse which keeps increasing as the time progresses up till year 5 and beyond. Next. Now, even before the development of third generation EGFR inhibitors, we had the first and second generation EGFR inhibitors like erlotinib, gefitinib, and icotinib. So all these first and second generation tyrosine kinase inhibitors were tested in the adjuvant setting after surgery and chemotherapy in early stage operated lung cancers which had a sensitizing EGFR mutation. Now, a very similar pattern which was noted in all of these trials was that as per each of these trials, which mandated a particular period of the adjuvant EGFR TKI, either 1 year or 2 years, in as long as the patients were on these TKIs, there was a significant improvement in disease-free survival. But after subsequent long-term follow-up, it became very clear that there was no significant improvement in overall survival in any of these trials. And because of this, there was no change in the practice guidelines until the development of third generation EGFR TKIs. Next slide. This is again a meta-analysis of all these trials, which is mentioning the same fact which I mentioned earlier, that as far as the disease-free survival is concerned, there was a significant reduction in the risk of disease recurrence as long as the patients were on the therapy. But when it came to long-term overall survival in the meta-analysis, there was no difference in the overall survival, and which is ultimately the most important endpoint that we need to consider, especially when you are treating patients in the adjuvant or the neoadjuvant space, because that is still the gold standard of the efficacy of the therapy. If a therapy does not translate to an improved overall survival, then there is not much benefit of giving it in the adjuvant space. You might as well as give it when the patient again relapses or has a stage 4 recurrence, because ultimately the patients are surviving for the same duration of time. So the real benefit of a therapy in the adjuvant or neoadjuvant space comes in when it demonstrates a overall survival benefit, but this could not be demonstrated by the first generation TKIs. Next. So it is very clear that these trials, earlier trials, they were smaller in size, they had some flawed design, and their protocols did not mandate brain imaging, and it was not clear if the first generation TKIs they actually resulted in curing patients or it just delayed recurrence. And there was no definitive evidence of how long these medicines had to be given, because of which the clinical practice still did not accept the routine use of these first generation TKIs post surgery. Next. So, keeping this in mind, the ADAURA trial was designed in this patient subgroup that is completely resected, that is adjuvant stage 1B to 3A NSCLCs, whether or not they received adjuvant chemotherapy. These are all adult patients who had the two sensitizing EGFR mutations. Brain imaging was advised. MRI was not mandated, but at least a PET CT scan was advised of the whole body. They needed to they had to undergo R0 resection, and then they were stratified by the race, the type of EGFR mutation, and the stage. And they were randomized to either placebo or 3 years of osimertinib, that is Tagrisso, which is a third generation TKI. The endpoint of the trial was disease-free survival, and this was in the stages stage 2 and stage 3A. Secondary endpoints were disease-free survival in the overall population, the overall survival, safety, and health-related quality of life. So disease-free survival was chosen as the endpoint, which is fair enough considering the fact that that is what the drug attempts to achieve. But it is also important to then look at the long-term follow-up of the trial and see the overall survival data as well. Next. So we all know there was the initial presentation in ASCO, which was again later updated in the again after a couple of years. We know that there is a stark contrast in the disease-free survival between the osimertinib and the placebo arms, with a very impressive hazard ratio of 0.23 in the stage 2 to 3A population and a hazard ratio of 0.27 in the overall population. And there was a huge difference in the median disease-free survival, with the placebo arm having a median DFS of 21.9 months, whereas the osimertinib arm had a median disease-free survival of 65.8 months. So overall, the entire population benefited but this was predominantly in the stage 2 and stage 3A, and it was to a lesser extent in stage 1B. Next. What we could make out was that without any evidence, without any doubt, that the CNS disease-free survival was significantly better, and this was expected because the drug is known to have a good blood-brain barrier penetration. If you see the blue line of osimertinib, right up till 36 months, where the medicine was mandated, there were hardly any CNS recurrence events. After stopping the drug at 36 months, you are seeing some patients having relapse in the CNS, which is why the curve starts dropping down. Whereas in the placebo arm, there was a constant CNS recurrence events emerging right from the beginning, from the 3rd to 4th month, and right till the 3rd and the 4th year also, the CNS recurrence events were consistently higher than the experimental arm. So this raises several questions to my mind. The first question is 3 years of adjuvant osimertinib enough, or do we need to give it even beyond 3 years? Because you're seeing that until the patient is on the medicine, the patient has CNS protection. Once you stop it, the CNS protection starts wearing off. So it is quite possible that patients might need osimertinib even longer than the trial mandated period of 3 years. The second question is, what is the protocol of brain imaging that has to be followed once the patient is, say, on the medicine, or when the patient is off the medicine? Do you need to increase the frequency of brain imaging once the patient is off the medicine? We don't know that exactly as of now. Next. We know that osimertinib is a fairly well-tolerated drug from our clinical practice. Unlike the first and second generation EGFR TKIs, side effects like severe diarrhea or severe skin rashes are lower. That being said, grade 3 side effects were noted in around 23% population, but side effects leading to drug discontinuation were uncommon, seen in around 13% population, and side effects leading to patient death were not seen. Next. So the takeaway points from this presentation is that we need to identify lung cancer early. We need to put in the screening programs wherever possible. Patients who are resected with early stage disease should absolutely undergo EGFR and ALK testing and PD-L1 IHC testing, because we will be hearing about adjuvant immunotherapy also in subsequent presentations. ALK mutation also now has the approved usage of ALK inhibitor in the adjuvant space. And we have seen that how giving EGFR inhibition with osimertinib in the adjuvant space drastically alters the natural course of the patient's illness. Overall survival is another point which was not covered in this presentation, but I did not include those slides on purpose, which is something which we can discuss probably in the panel discussion. Thank you.
So great, Shikhar. Now we move on to the panel discussion. While I can have my slides being presented, I request the panelists to be available. Dr. Sharat Chandra.
Yes, sir.
Pradeep.
I'm there, sir. Good evening, sir.
Naresh. Good evening, Dr. Sreekanth, Dr. Mahati, and Dr. Sai Krishna. This is an eminent panel, and have the presentation, please. So I just want to keep the presentation limited to only 3 aspects. One is on the oligometastatic disease, which is very often discussed. Second thing is double expression of PD-L1 as well as EGFR. We had enough data, but we just want to discuss upon how the evidence is evolving nowadays. And the third point, okay, do you want me to share? Yeah, that's okay. Thank you very much. The third point which we're going to discuss is about the CNS metastasis. I think Shikhar has covered a significant portion of it, and then left the most interesting part to us, to the panel, to discuss about those things. Can I have the next slide, please? So this is what actually I'm going to do. EGFR plus PDL1. We'll jump on to the first case. Next, please. This is the case. Next, please. A 65 years old man, non-smoker. He had cough and pleural chest pain for 1 month. CT scan showed 5.5 centimeters invading the pleural. The multiple lymph nodes were there. Effusion is positive for the malignant cells. Biopsy showed adenocarcinoma, TTF1 and absent present. NGS as well as PDL1 was sent as a part of package. And PDL1 is 95% and NGS shows EGFR exon 19 deletion by DNA technology. All other markers were negative. Do you want any further information? Let's start with Naresh.
Sir, I think we have CT chest imaging, sir. So I would like to go with systemic imaging with along with MRI brain.
Okay. So PET CT scan showing couple of liver metastasis. Brain is clean. And now I move on to the next panelist. Sai, do you want anything more?
Most of the times I would like to go for if there is any proven suspecting stage 4 disease, I would like to go with MRI brain also, sir, to rule out brain.
MRI brain is clean. MRI brain is clean, but is showing couple more bone mets and couple more liver mets. Madhi, do you want to have an additional liquid biopsy or you are happy with this solid biopsy? Because Rachana ma'am told that yield becomes 89% if you combine.
Yes, sir. Maybe we might pick up that 10% extra. Ideally, both liquid and solid would be nice, but practically that is difficult.
Yeah, but you already have exon 19. Do you expect any other mutations? He's having already two things to confuse us.
Now I'm not looking for any
PDL1, another is EGFR.
already got. Maybe we will be the liquid biopsy might give us some other mutations like probably some PP53 or any additional mutations that will just be of prognostic value rather than for treatment targets.
Great. Pradeep, how often do you see such cases?
Sir, very rarely I do liquid biopsy when I have already done tissue biopsy NGS, sir.
Right.
So when I already have the target,
you want
I
to
usually
reserve it
don't
for the
repeat,
next,
sir.
right, Pradeep? Yes, Sharath?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
I agree
Let's
fully, sir.
assume that the patient is everything in the world and they want to just go with a solid and liquid biopsy, and liquid biopsy showed ALK positive mutation in 2%. What will you do now?
No, sir. I'll be happy doing only liquid biopsy. Once it has picked up a
Solid
mutation, I
biopsy,
don't
happy.
take any further, sir.
Great.
I'm
Srikant,
happy with this.
Yes,
Yeah.
sir. And
Srikant, your opinion?
same, sir. And already it is picking EGFR, so liquid biopsy I don't prefer in this point of time, sir.
Good. So we move on to the next slide, what we did to the patient. Next, please. So we already discussed what routine molecular markers we had enough from Dr. Rachana. She covered almost everything. So we look for classical EGFR, all class MET and other things. How many of you people are interested in understanding RAS and NTR? These are two mutations, right? Are you insisting or you are going for a classical lung panel? Classic basic lung panel. Anyone can answer. I don't want to know any specific.
No, sir. No, sir. Nowadays we are doing broad spectrum, and they will cover most of all these RAS and NTRK mutations also. So
it comes with the same cost, so why to change? Great point. Well taken. How soon do you get PDL1 report compared to EGFR? In our hospital, they come at the same time. Sometimes PDL1 ahead of EGFR.
Most often
Sir, if it, so it depends on whether you're doing only EGFR or the entire NGS.
Okay. EGFR,
If you're doing only,
yeah.
If you're doing only an EGFR, I think PDL1 EGFR can come at the same time. But if you're doing an NGS, PDL1 IHC comes earlier, I think on day 5, and then the entire NGS will come on, let's say, between 14 to 18 days.
Correct, exactly. So any different?
And by that time, I think we would have already given our first cycle, and then We only want all these reports to be ready by the second cycle.
So that brings to the question. The third question. Pradeep, would you wait for EGFR report? Or you are good to start with PDL1? And when you are not sure, like a non-smoker or a female, you prefer to give only pemetrexed for the first cycle?
Yes, sir. I'll definitely wait for the EGFR report, sir, even if the PDL1 is high.
Great. So if the patient is symptomatic, you are comfortable with a short chemo while omitting the PDL1.
Yes, sir. I'll purchase sometime by giving some weekly chemo. And then by the time EGFR reports are high, I'll make the decision final plan considering PDL1 and EGFR reports at the same time.
I'll make it more interesting. How many of you, just yes or no answers, would prefer to give bevacizumab in this case? Or you just it's out of practice?
No, sir.
No, no, sir.
Unless someone is using the ABCP regimen.
Okay. Right. Very interesting, right? Rightly pointed
Yes,
out.
sir.
That's the reason I love the panel discussion. No, you always have a different perspective. Okay. So let us assume the EGFR. Okay. Let's go to the next slide, please. So these are two strong markers. We all know. So how to prioritize? Next, please. Discuss the evidence. All of us know the evidence, but I just want to update. Please, next slide. Next. Next, please. These are the two evidences which I'm going to discuss. Next slide. So osimertinib, irrespective of the PDL1 status, works. So inferior results were there when PDL1 inhibitors are given in EGFR. So you can give EGFR inhibitors if PDL1 is positive, but not the vice versa. That's the data that all of us know. Next, please. Next slide, please. And the NCCN guidelines tells about the same thing. Next, please. Okay, this patient progressed. One slide back. Thank you. This patient progressed and new mutations started appearing. What will you do? Then you would like to do a liquid biopsy, or you don't want to do anything else? You straight away go ahead with the chemo. We are coming to the second patient after a few minutes, but let's stick on to the first patient, the extension of it. Am I missing? Hello? Okay.
But
Most of the times isolated
would
bone
plan.
lesions.
I think it's a condition first case, I think, no, sir?
Yes.
In this case, I would prefer to go for tissue biopsy if it can be done. So if,
Right.
if it's not accessible, I'll go with liquid biopsy.
Right. Perfect. So, how many of you are in favor of starting chemotherapy along with TKI rather than changing it to immunotherapy? I think I'm having some problem in hearing. Hello?
If you're waiting for the liquid biopsy, I would prefer to start with chemo plus immunotherapy in that patient, sir, rather than combining with the TKI.
Okay. Right. Great. So let's go to the next slide, please. So the patient had a oligoprogression treated with stereotactic body radiation for the bone lesions. Osimertinib was continued for 8 months, post which the patient had progression on multiple lesions. right? So what would you do next? Next, please. We'll discuss about this in few minutes. Hello. Hello, I think I'm losing.
Yes, sir. I've just stopped
Yes,
your
sir.
video,
So,
so now you're audible, sir.
Yeah, so sorry. So sorry. Okay. Somewhere in I lost between small internet issue is there. You know. Good. Thank you. So now I'm clearly audible, right?
yes, sir.
Yeah. So local ablative therapy, how many of you prefer? Sorry, I missed hearing the panel. So quick one summary. Some of you can just give me the quick summary.
Yes, sir, definitely. In the case of oligo progression, in this case, definitely we would like to consider the if it is feasible for tissue biopsy, tissue, and if otherwise it is a liquid biopsy. In the oligo progression, definitely we would like to consider the
Local therapy.
localized therapy and continue the same treatment and until the progression, and we will reassess very frequently, and we will continue the same treatment after the local therapy, sir.
Right. So next, please. That is wonderful. That's exactly what the recommendations are. I'm sure. I'm glad that what we practice and what the recommendations, they conquer each. So next, please. Next slide, please. We'll go to the next slide. So this is a small cohort of say 19 patients, not a very big number, but the response rates are good and the durable responses. 11 months is decent enough for us to think about that this is something that is going to work very well. Next, please. So this is going to maximize the duration of EGFR TKI therapy and prevent switching into the systemic therapy quickly. So we need not stop if it is oligoprogression. Next, please. Unless liquid biopsies tell something else. There is one more abstract that supports the same concept. Next, please. Again, this is from India. Next slide, please. Again, this shows that, continued osimertinib in oligoprogression does have sustained responses if you treat the oligometastatic disease. So it's a wise option to continue with it. Next, please. As long as it is. So the last part, that is CNS metastasis. Very interesting thing. Next, please. So 53 years old woman, metastatic non-small cell lung cancer, diagnosed 1 year earlier as a stage 3A, classical of what we heard about the adjuvant EGFR presentations. There's a very interesting point he brought out. When to do MRI scan sort of thing. Okay, so on the right side, it is 1 year, it's violet. NGS showed mutation EGFR. Brain MRI was done, negative for mets at the beginning. TP53 is present. Okay, so I don't know how many of you consider that is significant in choosing between adjuvant chemo versus adjuvant chemo. We have data with only vinorelbine versus EGFR, right? So her treatment consists of right lung and mediastinal irradiation concurrent with paclitaxel. Paclitaxel, mind you, was not the arm which was chosen in the adjuvant therapies in the beginning. Later it came into the picture, and SRB was given, but showed most of the things were clear. 9 months later, PET is repeated, showing a mild progression. MRI brain was repeated at this time, thinking that a progression in the chest may have a progression in the brain. You have a METS 3.1 centimeters. I hold here. I just want to understand from the panel, how many of you people in the beginning would have offered chemotherapy in the era of EGFR positive? Question number 2 is, do you believe that osimertinib, by virtue of its ability to reduce the brain mets obviously may not have any OS benefit as expected, but do you think that you could have prevented in this case, or it doesn't make any difference whether you start now or after the recurrence? Both the questions open to the panelists. Am I hearing you people, or again?
Sir, adjuvant chemo followed by adjuvant osimertinib, definitely.
Only
Only-
adjuvant osimertinib, you are not in favor of it?
I mean, if the patient is not fit enough for the chemo.
Okay. Because TP53, what makes you think in that lines?
I mean, the trial had an open option. Only the physicians chose for adjuvant osimertinib when the patient is not fit enough for chemo. So I still believe chemo has its role, and with 5% OS benefit back from 2 decades ago, we still try and follow that. And then the adjuvant osimertinib again, and both the approaches put together will give my longest PFS is what I believe. And then TP53 definitely chemo would try and cater to that.
Right. Pradeep, what do you do?
Sir, I agree, sir. In Adura trial, the main arm was chemo followed by osimertinib, unless the patient is not fit. I think that will yield the maximum PFS.
Naresh?
So regarding this patient, you're asking, or in general post-adjuvant?
This patient only.
So this patient actually, I think he's CTRT. So post CTRT, I would go with LAURA trial, sir. I would go with osimertinib.
Right. Okay. So would you are you in lines of giving chemo followed by TKI or only TKI? What is your choice?
In adjuvant setting, sir, you're asking?
Yes, in adjuvant setting.
So in adjuvant setting, I'd go with chemo followed by TKI, sir, because if you see the curves, long-term curves, so there was early separation. If you see chemotherapy plus followed by osimertinib compared with only osimertinib arm, and the magnitude benefit also was better in the chemo followed by osimertinib arm.
Right. Srikant,
yes,
your
sir.
opinion,
And
please.
in this particular case, adjuvant chemo followed by adjuvant OC, sir.
So you feel that the people did a good job, but they didn't give the TKI in this case. Okay,
Yeah.
let's go with the next slide, please. Okay, so currently, because she had only isolated brain met and a small node in the mediastinum, would you like to treat both or only one? And what is your choice of the systemic therapy? I start with Mahati and then Sai Krishna.
A patient is having symptomatic CNS metastasis, I'll definitely go for a multidisciplinary tumor board discussion with a neurosurgeon and a radiation oncologist. For symptomatic CNS mets, would prefer if the feasibility of, will explore the feasibility of surgery and radiation to the brain, followed by systemic therapy, sir.
Okay, if it is asymptomatic, then?
Asymptomatic, the targets are there, systemic therapy first.
Okay. Sai Krishna?
Yes, sir. If they are asymptomatic, I would like to go with the systemic therapy first. Unless patient is significantly symptomatic, would like to consider first the local therapy, simultaneously following by systemic therapy, sir.
What will you do for the mediastinal node?
No, with the systemic therapy only, I would like to consider.
Great. Next slide, please. So, as our panel expected, we started on osimertinib. In retrospect, she had been suffering from the ataxia, worsened with significantly. Started on DEXA, scheduled for craniotomy and tumor resection following week. MRI 15 days, significant reduction in the cerebral tumor, close to 94% volume reduction. There is a near complete resolution of the edema and mass effect. Patient symptoms are not there. Steroids were rapidly tapered. Surgery was cancelled. Are you happy with the cancellation of surgery?
Yes, sir.
You're
Yes.
happy. Okay, great. So, yeah, obviously, some people do respond very well with this therapy, right? Day 60 showed almost zero tumor, 0.3 centimeter cube. Hardly it is measurable. So the top point here, I don't know whether I can use my pointer, but this is exactly where the tumor is. Okay, next please. So the PET scan is suggestive of brain mets. Do you still require MRI?
Yes, sir.
Yes, sir.
You're not happy with PET showing that it is a mets. I'm not talking about missing one.
No, sir.
No,
We'll
sir.
still go ahead with brain MRI.
Exactly, we need a number of mets and also size of the mets.
Exactly.
Definitely.
Oligo versus polymetastatic disease, you can't
Yeah.
tell unless you have a MRI in your hand. Great. So, okay, it's well-controlled symptoms. She continued well on anti-epileptics and dexamethasone. Question which bothers us is how long to continue on steroids? Never answered question. Neurosurgeon wants 12 weeks, radiation oncologist wants 6 weeks, medical oncologist, your choice. Go ahead.
Medical oncologist will only trust on osimertinib, sir.
Okay, you don't take dexamethasone.
Take care of
Wonderful.
brain mets.
Great. So nice one. Next, please. Next slide, please. Okay, this we all know. I need not go about it. Next slide, please. The study of demonstration of efficacy of osimertinib. We all had this study. Next, please. I'll quickly run through it. So that shows both OS and PFS improvement. Next slide, please. The Flora trial design showed in CNS mets, it does a wonderful job. Next, please. The responses are phenomenal, like what you observed in the MRI. Next, please. So they responded along with complete responding in a few of these patients. CRs was observed. Next, please. So the efficacy in CNS directed therapy as well as ORR, great. Next, please. So in asymptomatic patients, the honest answer, how many of us will follow with MRI brain if the patient is having a CR with osimertinib?
I mean,
Based
if
on
he
bravery.
already had an upfront brain met, sir, or as a
Not in
follow-up.
case. In general, I'm asking in general, if the patient is asymptomatic, okay, you did a baseline MRI, no meds, you started an osimertinib, so you continue to follow up with PET scan. PET scan continue to be in remission. How many of you still go ahead and then ask for a repeat MRI?
That's a tricky question.
As long as patients are asymptomatic for the brain, we are just following with PET CT now, sir.
With a special brain cut, sir.
Yeah.
Okay. Naresh, you don't ask for it, right? At least
No.
once in 6 months, once in a year.
Usually, I follow PET CT. Sir, if PET CT is in CR generally, and patient is asymptomatic, I would not ask for MRI, sir.
You trust osimertinib. You don't believe that 40% can be misses. 40% still
Sir,
can miss.
are we right in doing that?
I'm asking the question to the panelists. See, the moderator need not know the answers, right? That is the best advantage of being moderator. Every answer is the right answer. That's the advantage of the panelist.
Retrospectively, but now we are thinking that probably we should do MRI along with PET CT.
Or MR PET sort of thing, right? Okay.
Yes.
So, fine. That's great. Next, we'll just conclude in a couple of slides. Next, please. So, these are the guidelines. It doesn't say we need to do the MRI. Next, please. So again, this is a package instead of the osimertinib. But what I want to say is this drug, by virtue of its CNS penetration, do a wonderful job. Number one, in those with brain metastasis. Number two, those who develop brain metastasis while on other therapies. Number three, even though the patient progresses on osimertinib, if it is a oligoprogression, you can still continue the drug while treating the metastatic lesions. Most important thing is keep your eyes open and mind wide open for the options or possibilities of having another mutations in these patients. Next, please. It's a well-tolerated drug. Thank you very much, AstraZeneca, for giving the opportunity. And thanks, panelists, for the wonderful discussion. I am
Sir, what do you
handing
do
it
in
over.
other settings?
Sorry?
Sir, one question for you, sir. What do you do in other setting post surgery, adjuvant, chemo followed by adjuvant OC, or only adjuvant OC?
Chemo followed by adjuvant OC. That's what I do in my practice.
Okay, sir.
Right. Thank you. Thanks for bringing the point and then making it very clear. So 8 o'clock sharp. We covered up 5 minutes time. Great. we have a great panel who was very quick in running us through all those things. Now I hand it over to the Srinath. Srinath, are you there? To take us through the immunotherapy in early lung cancer.
I'm there, sir.
Great. Go ahead, please.
Request AstraZeneca to share the slides, please.
Srinath, we need to finish everything by 8:20. You have 10 minutes. Thank you. Great. Srinath, you are on mute. You need to speak. You need to unmute, Srinath.
Yeah. Firstly, I would like to thank AstraZeneca India, Pamina Creations, and Dr. AVS Suresh sir for giving me this opportunity. We will discuss perioperative immunotherapy in resectable lung cancer, a new frontier. Definitely, it's a new frontier, but I think it has a lot of loopholes too, which we'll explore in the coming slides. Next slide, please. So definitely, all lung cancer cases were more than 2 million reported new cases worldwide, and 85%, 80 to 85% is contributed by non-small cell lung cancers, and roughly 1/3 resectable, 25 to 30% come in a resectable stage to us, maybe a bit more or less in India. And surgery with curative intent will definitely be the primary treatment in patients with resectable disease. But as we all know, as the stage increases from stage 1 to stage 3, the chance of recurrence keep going up, and hence we are justified in giving some form of adjuvant therapy. Most probably it is chemotherapy in the initial days, and now it has come up to immunotherapy. So from 1B to stage 3, 45 to 75% chance of recurrence or death. So next slide, please. So there is definitely an unmet need here to decrease the disease recurrence and improve survival in resectable NSCLC. Adjuvant cisplatin-based chemotherapy is recommended for all patients with resected stage 2 to stage 3A NSCLC, and select patients with stage 1B. Rates of disease recurrence following surgery remain high that we have seen, and precisely adjuvant chemotherapy has yielded a 5%, precisely 5.4% survival benefit at the end of 5 years. So did neoadjuvant chemotherapy in borderline resectable stage 3A. So perioperative regimens could further improve long-term clinical outcomes by combining the benefits of this neoadjuvant and adjuvant. Chemotherapy is already proven, and now in the past 2 to 3 years, we had several trials which kind of checked efficacy of the immunotherapy in both neoadjuvant setting, perioperative setting, and also adjuvant setting. And next, please. So neoadjuvant and adjuvant immunotherapy have shown promising results with acceptable safety profiles. Neoadjuvant immunotherapy has several advantages: potential for more robust and durable anti-tumor responses against micrometastatic disease than adjuvant IO, potential for preventing immune tolerance and escape mechanisms that occur in early stage disease, which will eventually lead them to progress to stage 4. And combining neoadjuvant immunotherapy and chemotherapy and further adjuvant immunotherapy is expected to improve activity and long-term clinical outcomes. That we have seen with the recent update of Keynote 671, where there we could see a statistically significant overall survival benefit, and chance to treat patients who are not immunosuppressed, better treatment compliance, and decreased possibility of resistance due to limited exposure compared with adjuvant IO. Adjuvant IO also has demonstrated better DFS benefit with pembrolizumab and atezolizumab. But which approach is better? I think we will discuss it at the end of the session. Next, please. So these are the trials. Checkmate 816 has checked the efficacy of nivolumab only in the neoadjuvant setting with 3 cycles, and it showed improved EFS and improved pathological complete response. IM Power 10 discussed about the efficacy of atezolizumab in the adjuvant setting after the adjuvant chemotherapy, if indicated. It improved DFS, especially in only select population of PDL1 more than 1%. Keynote 091 or the Pulse trial, again improved DFS with adjuvant pembrolizumab. AGN trial, perioperative chemotherapy plus durvalumab improved event-free survival. Neotorch trial, the Chinese trial, improved DFS with toripalimab. And also tislelizumab also showed improvement in EFS in the Chinese trials. Keynote 671, as we discussed, not only improved EFS, the update has shown improved overall survival also. Next, please. So regulatory statuses, I think nivolumab is approved in the neoadjuvant and the perioperative settings. Atezolizumab and pembrolizumab again approved in adjuvant setting. Pembro is approved in perioperative setting also. Toripalimab and tislelizumab, I'm not sure if there's FDA approval. There's no FDA approval. And Checkmate 77T, the data is out, and I think it showed similar EFS compared to both pembrolizumab and durvalumab, and it also has regulatory approval. I don't know, it's not mentioned here. Sorry, the slides are from AstraZeneca. Next slide, please. So here we are here to discuss a particular trial with specific emphasis, that is the AGN trial. It's a phase 3 randomized double-blind placebo-controlled trial comparing perioperative immunotherapy with durvalumab, that is neoadjuvant durvalumab with chemotherapy for 4 cycles, followed by 12 cycles of adjuvant durvalumab versus placebo. So the inclusion criteria include resectable NSCLC from stage 2A to 3B, that is according to AJCC 8th edition, because stage 1B has shifted from more than 4 centimeters of the tumor size has shifted from 1B to 2A in stage AJCC 8th edition. And patients eligible for pneumonectomy, that is T4 lesions with lesions in 2 different lobes of the same lung, they were excluded. Only patients eligible for lobectomy, sleeve resection, or bilobectomy as planned surgery were included. And confirmed PDL1 status by IHC using SP263 was mandatory. And no documented EGFR or ALK aberrations have to be proved. The primary endpoints of the study were EFS EFS and pathological complete response. And the secondary endpoints were major pathological response and DFS and OS using blinded independent central review, both for EFS and DFS. Agent study, the question is, does neoadjuvant durvalumab plus chemotherapy followed by adjuvant durvalumab improve PCR and EFS in resectable stage 2 to 3B compared with neoadjuvant chemotherapy plus placebo? Next, please. So the baseline characteristics were largely balanced, and the planned neoadjuvant CT doublet regimen was carboplatin based for more than 70%. I think this has to be noted. And majority could complete the neoadjuvant setting. Almost 80% could receive the planned neoadjuvant regimen. And as far as histology is concerned, squamous and non-squamous were almost equal. PDL1 expression less than 1 to 49, and 50, more than or equal to 50 were also equally balanced as 33% roughly of each. And majority were white. Asian population was around 40%, and blacks were less than 1%. Majority were males, and the median age was around 65. And majority, as we discussed, received carboplatin in the chemo doublet rather than cisplatin, which was quite against the LACE meta-analysis, which showed cisplatin is the only drug which is kind of showed benefit in the adjuvant and neoadjuvant setting, and carboplatin virtually has no role except for clinically substituting it when the EGFR is less. But I don't know really why the carboplatin was used. Maybe as a part of, I mean, in the curative setting, cisplatin has proven benefit. Next, please. So the updated EFS, second planned interim analysis in the modified intent to treat population. Why the intent to treat population was modified? Because after the ADAURA data, which was released during the trial, the EGFR and ALK were completely removed from the study, and around 60 patients have gone out of the study. And the EFS benefit favoring durvalumab arm was maintained and consistent with that reported previously. So at 36 months, you can see the EFS difference 60% versus 48%. Yeah, next, please. So there was a pre-planned subgroup analysis regards histology, disease stage, and PD-L1 expression. And durvalumab equally benefited irrespective of the histology, whether squamous or non-squamous, whether disease stage 2, 3A or 3B, every more or less, but every stage benefited. And lymph node stations, N2 single station benefited much more compared to N2 multi, but that was not really statistically significant. And PD-L1 expression at baseline really did not matter, and all the groups did equally well. And irrespective of the platinum used, irrespective of the cisplatin or carboplatin, the patients benefited equally, to our surprise. Next one. So clear and consistent EFS benefit is observed regardless of the planned platinum agent that we discussed. Next, please. So the pathological complete response is almost 18% versus 4.3% only with chemotherapy, which is consistent with Keynote 671, in which even pembrolizumab showed 18% pathological complete response versus 4% with chemotherapy. And MPR also is consistent with various other immunotherapy trials, including nivolumab, which showed around 33% MPR rate versus 10 to 12% MPR rate with placebo arm or chemotherapy alone arm. Next, please. PCR by subgroup also did not matter. Almost all the stratified factors like histology, disease stage, PD-L1, irrespective of that, the PCR was achieved equally in all of them. Next, please. Adverse events were more or less similar and were more predominantly chemo-related rather than immune-related. Obviously, the immune-related adverse events were more in the Duro arm, 23.5% versus 10% in the placebo arm. Majority were grade 1, grade 2, and grade 3, grade 4 grade 3, grade 4 adverse events leading to discontinuation of the study molecule were more or less equal and very much less. Next, please. So the most common side effects were also again predominantly dominated by the chemotherapy. And in the durvalumab, the major side effects were pruritus and rash, which were majorly grade 1 and grade 2 and were easily manageable. It didn't cause any specific adverse event more than what is expected with chemotherapy to cause discontinuation of the drug. Next, please. So again, immune-mediated adverse events, hypothyroidism was there, 9.2%, and dermatitis and rash, we discussed 5.5%. Pneumonitis was less than 5%, and diarrhea or colitis is less than 1%. Next one. So stage 3 is a highly heterogeneous based on tumor size, node, and other tissue involvement. Only selected patients in this stage will be candidates for resection, especially 3B. So all stage 3 cases should be assessed by MDT before treatment. And less than 22% with 3A and less than 5% with 3B received surgery as a part of the treatment as per the UK audit data from 17. But here, surprisingly, when we go to the subgroup analysis, I don't know whether it is mentioned, but 50% were N2 positive in this study, but 75% went on to undergo surgery. So the PathCR being 18%, I was a bit confused as to how really this happened. I'm not sure of the answer yet, but that's how it is. So majority were dominated by T3 and N2 in agent study population. Next, please. So again, we have discussed neoadjuvant or perioperative approach versus adjuvant approach, which is better. We really don't know. But right now, cross-trial comparisons, which are not the correct way of assessing data, still, but if we numerically see it, I think perioperative versus adjuvant approach seems to be slightly numerically better than the plain neoadjuvant approach, because other aspect of neoadjuvant approach is only 25% to 30% could achieve PathCR in the nivolumab neoadjuvant study, and nothing was given in the adjuvant setting. So that is the maybe the deficiency of the neoadjuvant approach studies. In the perioperative approach, the majority of the chemo versus immuno was compared in the neoadjuvant setting again, and the contribution of adjuvant chemotherapy was completely ignored. Despite people only 18% PathCR, the 82% who didn't achieve PathCR were also not given adjuvant chemotherapy. I think that is one of the cons of perioperative trial approach, is what I felt. And the other thing which bothered me was in Keynote 671, majority received cisplatin, which has a definite survival benefit as per Lace meta-analysis in the neoadjuvant or adjuvant setting, where Asian population received more of carboplatin. Of course, they got a response irrespective of the platin, but would the response be much more, or the PCR or the event-free survival points, percentage points, be much more if cisplatin was used more? Is always a question which will keep coming up. And as far as adjuvant immunotherapy is concerned, the numerically perioperative or adjuvant seems to be doing equally okay. But I think with the overall survival benefit of the Keynote 671, I think perioperative chemoimmunotherapy approach would definitely take a front seat after all this data. And selecting molecule to molecule, I think numerically there is not much of a difference. But again, documented overall survival currently is with pembrolizumab. I think overall survival data is yet awaited for a agent trial. So with this, I conclude and hand over the mic back to Dr. Suresh, sir. So
Thank you, Srinath. Great long session. Tried your best to finish in 15 minutes. Sincerely appreciated, and your points of cis versus
thanks, sir.
carbo and all
Any
this
comments,
is very
sir,
well taken.
among
Points are very well taken. Now we go to the last session, and if you have any questions, I'll take it up if time permits, because we are having just 10 minutes time. Sreekanth, you have a task of giving us the vision of metaxon 14 skipping mutations in lung cancer patients.
Yes, sir. Thank you, sir. Good evening, and thank you for giving this opportunity, Dr. Suresh sir and Merck Oncology, for giving this opportunity, and good evening to one and all. And today I would like to go through the metaxon 14 skipping mutations, what are the drugs which we are having, and just I would like to highlight the what is the vision trial and all these things. And next slide, please. And if you look at the metaxon 14 incidence, it comes around the 3 to 4% of patients with non-small cell lung cancer. And in the real world and in our clinical practice, and what I am seeing is that around 2% of cases are showing the metaxon 14 alterations. And out of all these things, throughout the world, and metaxon 14 comes around 3 to 4%. And it's already we are very well aware of it in the lung malignancy. The oncogenic driver mutation testing is still evolving, and it is going on continuously. The research is going on continuously to develop the targets and to develop the particular target therapy for that. And definitely molecular testing is most important in non-squamous NSCLC. Next slide. And these are the guidelines which we are following, NCCN and ESMO guidelines. And those who are patients with metaxon 14 skipping NSCLC, the preferred first line therapy what we are having is there are two drugs that is called as one is tepotinib and another one is capmatinib. And previously in 5 years back, and what we are using is crizotinib in previously. And with the coming data with the both the drugs and the tepotinib and capmatinib, and we are using the these two drugs. And today I would like to discuss because of the Merck they are giving the slides, and I would like to enlighten the tepotinib. So next slide. Yeah, if you look at the vision study, and this is the largest study and in the world, and which is involving the nearly more than 300 patients, those who are exhibiting a MET exon 14 skipping mutation. And this is the first clinical trials of MET inhibitor, which is done as prospectively enroll the patients based on both liquid and tissue biopsy. And the median age of patients comes around more than 70 years, and more than 30% of Asian patients are enrolled in the study. The study with the both treatment in the particular study they are included both treatment naive, that is and previously treated patients with 18% with the brain metastasis. Next slide. If you look at the design and baseline characteristics, and they are included, this is the phase 2 trial of tepotinib. And if you look at the inclusion criteria, and those who are metastatic NSCLC exhibiting the MET exon 14 skipping, and which is detected by both liquid and tumor biopsy, no prior treatment with therapies which we are targeting with MET exon 14, and less than or equal to 2 lines of prior therapy. They are dividing into 2 cohorts, that is A and C, and they are giving the tepmetco for 450 milligrams once per day, and they are included the treatment naive and previously treated patient, and which is done almost 1:1 randomization is there. And they're considering the primary endpoint overall overall response rates, and secondary endpoints they are including duration of response, PFS, OS, and safety. And this is the large population of study, and they are dividing into the treatment naive and previously treated patient. Almost they are dividing into 1:1, and if you look at the all baseline characteristics, and they are included 1:1. And if you look at the line of treatment, in the first line and those who are treatment now, it is 100% patients are included. In the second line, more than second line, third line, they are dividing into the 161 and 38% of patients. Next slide. And this is the first clinical trial of MET inhibitor, and already prospectively including the patients with alterations based on the liquid and tissue biopsy. If you look at the on the right side, if you look at the in the liquid biopsy, though exhibiting the MET exon 14, and they are also dividing into the treatment naive previously treated, as well as in the tissue biopsy also. The overall patients are they are dividing in the overall patient they are considering 275 members, and out of that only 36% of patients are only liquid biopsy positive MET exon 14, and 21% are both liquid and tissue biopsy positive. 42% of patients belongs to tissue biopsy positive MET exon 14 patient. Next slide. And if you look at the efficacy in the treatment naive patients and those who are enrolled in the detected by the tissue biopsy of MET exon 14, and if you look at the overall response rates, it is comes around 58.6%. Median duration of response, it is 46.4 months. Median PFS is 15.9 months, and median OS is 29.7 months. And if you look at the waterfall plot, and there we have a complete response rates and partial response rates, stable disease, and progressive diseases are very, very rare. And most of the tumors are those who are expressing MET exon 14 with tepotinib are consistently sensitive to tepotinib. And this is the slide which belongs to the treatment naive patient. Next slide. And this is the slide showing you those who are already previously treated patients, and which is detected by the tissue biopsy. If you look at the overall response rate, it is around 50%. Median duration of response is 10.2 months, and in the treatment naive patients, it is comes around 40 months. And to previously treated patient, it is 10.2 months. Median PFS is 11.5 months. Median OS comes around 20.4 months. And in this setting also, the MET exon 14 expressing tumors, they are also showing consistently sensitive to tepotinib. Next slide. And tepotinib, this is the particular drug which is showing the intracranial activity. Those who are patients who are already having a brain metastasis. At the baseline, 57 patients had brain metastasis. And if you look at the intracranial disease control, it comes around 88.4%. Intracranial response is 67%. And intracranial median PFS, that is 20.9 months. And intracranial median duration of response is not attained till now. And if you look at the intracranial response rates in the patients in the target lesions, and if you look at the waterfall plot, and if you look at the out of in the corner, and you are seeing the complete response of targeted lesions, and we are showing the partial response, stable disease, and stable disease also. And if you look at the MRI of the baseline of the one particular case, that is one target lesion which is of 11.1 mm size in this location, and if you look at the week 6 of tepotinib, and the target lesion is comes around 5.8 mm, and at the week of 36, and there is no visible lesion at all in this particular case. Next slide. And if you look at the efficacy, and with the tepotinib, it has a robust and durable response, durable in the treatment in Asian patients. And if you look at the overall response rates in the Asian patients, it is 64%. Median duration of response is 20.7 months, and median PFS is 16.5 months, and median OS is 32.7 months, which is quite significant, that too particularly in the Asian patients. And all these are in the first line setting. And if you look at the waterfall plot also, only the treatment is not evaluated in only one case, and progressive disease in one case. The rest of the cases are showing the complete response to partial response. Next slide. And this is in the second line setting of the tepotinib, which is in the Asian patients in the patients in the second line setting, and the overall response rate is 50%, and median duration of response is 10.8 months, and median PFS is 12.1, and median OS is 23.7 months. Next slide. And these are the two drugs which were actively available in the market. One is tepotinib, another one is capmatinib. And if you look at the trial, and the number of patients is enrolled in the tepotinib is 313, that is 313 patients, and in the capmatinib it is 160 patients. And if you look at the potency, with the tepotinib it is 1.7 IC50, and with the capmatinib it is 0.13. And if you look at the brain penetration percentage, it is 25%, quite significant with tepotinib. Compared with capmatinib, it is 9%. And if you look at the CNS endpoints and brain penetration and tumor shrinkage, those who are positive for the brain metastasis, and 88.4% have a intracranial disease control rate, and 66.7% have a intracranial control rate with the tepotinib. And with the capmatinib, and 54% of patients are having the intracranial response rates. And if you look at the dosing, and 2 tablets per day, that is 450 milligrams once per day with the tepotinib, and this is the one-step dose reduction schedule. And capmatinib, there is a 4 tablets per day, that is 800 milligrams twice a day, and we have a 2-step dose reduction schedule requiring depending on the toxicities. And testing, and in the vision trial, and they are included both tissue biopsy and liquid biopsy. In the capmatinib, that is geometry trial, they are included only tissue biopsy, NGS, or RT-PCR. If you look at the overall response rates, and with the tepotinib in the first line and second line setting already, which we have discussed, they are dividing into the overall response rates and Asian subgroup patients, and the Asian subgroup patients are showing better overall response rates compared with the overall population. And if you look at the in the overall population, tepotinib has a median duration of response is 46.4 months, and out of all parameters, and they are showing the edge over the capmatinib, tepotinib showing clear-cut edge over the capmatinib. Next slide. And this is the tepotinib versus capmatinib, which is showing the superior outcomes. And if you look at based on the all characteristics they are taking, and with the median OS is with the tepotinib, it is 29.7 months versus 20.7 months. Median duration of response is 46 months versus 12.6 months. Median PFS is 22 months versus 12.3 months. Overall response rate is 59% versus 67%. In the second line setting, tepotinib versus capmatinib, in all aspects, they are showing the clear-cut edge, and median OS, median duration of response, PFS, and overall response rates. In the second line setting, tepotinib take over compared with capmatinib. Next slide. And why what is the need for the tepotinib in the metaxan 14? And we have a largest trial in the metaxan 14 skipping mutation, which is a vision study. They are included both liquid and tissue biopsy, and this is they are included the prospectively. They are actively enrolling the patients, and in the first line setting, we have a clear cut over the capmatinib. In the second line setting, also results are showing same compared with capmatinib. This is the only MET inhibitor with once daily dosing. And regarding the brain penetration and intracranial disease response rates, and it has a clear-cut advantage compared with capmatinib with a 25% of brain penetration and nearly 89% of intracranial disease control rate. And with the concentration of the drug that is in the first line outcome, tepotinib versus capmatinib, the median OSS comes around 29 months versus 20.7 months. And this is the convenient and one-step dose reduction is there with the tepotinib, and this is the drug which is recommended by both NCCN and ESMO. And next slide, I think this is the last slide. And next slide, please. I think I would like to stop here, and thank you again for giving this opportunity.
Thank you, Srinath. You have the topics. Now, we are already running late by 10 minutes. Can a couple of questions from the audience, if at all anything is there. Otherwise, I hand it over to the organizers and thank everyone, the speakers, the panelists, the people who spend their time on a holiday weekend sort of thing, and especially the organizers getting the opportunity to share. Couple of quick questions I can take. Otherwise, I thank and then hand it over to the organizers. Any guidance in amplifier EGFR resistance? Srikant?
Sir?
Any guidance in MET amplifier EGFR resistance? There's a question that we could see in the chat box.
Any guidance in MET amplification after EGFR resistance? And I never encountered, and we are regularly sending the liquid biopsy after those who are progressive disease on EGFR target therapy, and I never encountered MET positivity at that time. And in the upfront cases, we are regularly, and I have 2 cases on tepotinib, and I have a very good experience on that. And in this particular question, and I don't have any experience on that, sir.
Perfect. Thank you. I think we'll stop here and hand it over to the organizers.